and welcome this to the Sunday monthly transplant series. And I'm Anshul Bhalla. I'm a transplant nephrologist, and I'll be moderating the session today. I would request everyone to leave their questions in the chat, and towards the end of the talk, we'll get to all the questions. And it gives me great pleasure today to invite and introduce Dr. Babak Orandi, who is our speaker for today.
Thank you very much. Thank you for that kind introduction and the opportunity to speak today. And thank you to everyone for spending a little bit of time on your Sunday here to listen to me talk about this. So we'll just get started. These are my disclosures. I will be talking about some off-label use of drugs. Today, I want to talk a little bit about the implications of obesity and weight loss, both for access to transplant and outcomes after transplant. We'll talk a little bit about the obesity paradox as it relates to the pre-transplant population. And then we'll talk a little bit about some select weight loss strategies for these patients. I think it's maybe worth just mentioning kind of how I ended up in this. I was on faculty at the University of Alabama at Birmingham, where, for those of you who are not familiar with some of the geography of the United States, they're in the deep South, where obesity is probably at its most severe in the entire country. Took care of a lot of patients with obesity that really precluded them from eligibility for transplant, and I was sort of frustrated by my inability to help them. And at the same time, I was fortunate enough to be involved in some of our efforts in xenotransplantation. And while it was super exciting work, cutting edge, and it's certainly very sort of attention-getting, as I was working on it, I just kept thinking to myself, wow, this is, what a country that we can't. This is the solution to the organ crisis, is to genetically modify pigs and try to make them work in humans. And for me, I think my ethos is a bit more about trying to be on the prevention side of things, that maybe if we focus on comorbidities that lead to dialysis and to end-stage kidney disease, maybe we can avoid the need for transplant altogether. And by focusing on reducing demand, we may meet that supply and demand mismatch. And so that's what ultimately kind of led me down this path. And so, this is data from the CDC that they do this annual survey. And you can see over time, from the time I was a high school freshman until just recently, the dramatic change in the prevalence of obesity in the United States. I don't think this is a surprise to anyone. And I will acknowledge that there were some methodologic changes somewhere between 1994 and 2023, that it's a little bit of a sort of not quite apples to apples comparison, but you get the general idea that obesity is steadily on the rise. And at the same time, so is kidney disease, end-stage kidney disease. And so these are data from the United States Renal Data System. And you can see over time that we just have this steady increase in the number of incident cases of end-stage kidney disease. But it's really interesting when you break it out by cause, so I'll sort of draw your attention to the upper right corner. You can see that sort of other causes, so things like IgA nephropathy, congenital anomalies of the kidney and urinary tract, all those things are largely sort of holding constant year after year. And then when you look at diabetes and hypertension, which you can see in that lower right corner, you can see that that is steadily on the rise and really matches that increase in prevalence, or incidence rather, that you see in the general ESKD population. And so much of diabetes and hypertension is driven by obesity. And then on the post-transplant side, obesity is a major problem. So assuming you get to transplant, weight gain is really common after transplant. 3/4 of patients are going to gain a significant amount of weight in their first year, on average about 7 kilos, but a third will gain at least 10% of their body weight. And so for patients who are already starting off with obesity at the time of transplant, this can really lead to a significant amount of post-transplant weight gain and worsening of the comorbidities that ultimately, for many of them, end up sort of diminishing their overall quantity and quality of life post-transplant. We see that the implications of obesity are pretty widespread as it relates to renal function. So, we sort of think about a lot of the damage that obesity does mediated by the development of diabetes and hypertension. And certainly those are major components of how obesity impacts kidney function, whether it's native kidney function or on the post-transplant side. But there are also a lot of direct effects. There are things like oxidative stress from obesity that puts a lot of pressure on the venous system, which causes venous reflux into the kidney. So there's all these different things that lead to kidney damage. And so what that means, both in terms of pre-transplant, it means that we're seeing an acceleration. You're going to see, well, we'll talk a little bit about what we see on the post-transplant side, but what we did this study a couple of years ago where we looked at a 2-year incident dialysis cohort. And among 160,000 incident dialysis patients, there were about 40,000 that had obesity as their only isolated identifiable contraindication to transplant. And that as their obesity went up, their likelihood of getting listed went down. That's in the upper right corner. And even conditional upon listing, their likelihood of getting transplant was still lower than those who had a lower BMI. That's in the lower right corner. And the patients that were most affected tended to be young, they tended to be Black, they tended to be women. And so this is the population who probably have the most to benefit from transplant are really struggling to get access to the wait list. And certainly this is partly because of structural barriers that we have in place. This is data from a national survey that we did. It's under revision right now as part of the American Society of Transplantation Kidney Pancreas Community of Practice Obesity Work Group. That's kind of a mouthful. But we found that 3/4 of US transplant programs use a BMI cutoff for evaluation and for waitlisting. And it's most commonly 40, but there are a number of programs that use a BMI below that to preclude patients from access to transplant. And in that setting of once patients are listed, some of you may have seen this article. It was about a month and a half ago, came out in the New York Times that talked about out-of-sequence organ offers. And so for those of you who aren't as intimately aware of transplant, sort of how organ offers are made, we have, as a society, as a community, we've decided how we think transplants should be allocated. A lot of it relates to how long you've been on dialysis or how long you've been listed. Some of it relates to age. Some of it relates to how sensitive